Welcome back again. Today's lecture is implant-supported fixed restoration. First, we get acknowledged with some definitions or terminology of that part or that section of our curriculum. A dental implant is a biologically compatible biomaterial surgically inserted into the hard tissue, the oral cavity, and that is for the functional and cosmetic purpose, which serve as a foundation for prosthodontic restoration, while the implant prosthodontic is the branch of implant dentistry concerning the restorative phase following implant placement and overall treatment plan component before the placement of a dental implant. First, we need to know, is a dental implant a suitable solution for all the patients? Some yes and some no, yeah, or which cases it is indicated for this kind of treatment. Advantages of an implant, restoration implant, fixed prosthodontics is we acquire no reduction for the adjacent teeth, bone stabilization and maintenance, retrievability of the restoration, improvement of function, and psychological improvement for the patient also. While the disadvantages is concerning the problem, the mechanical problems that may happen with an implant, like risk of screw loosening, this is the screw, a risk of fracture failure, length of treatment plan, need for multiple surgeries, and challenging aesthetics. So you may have a problem with screw loosening that would lead to bending and eventually fracture of the screw. Indication: implant fixed prosthodontic is widely accepted for patients who are having a problem of wearing a removable partial denture or complete, a need for long span fixed partial dentures with questionable prognosis, unfavorable number and location of potential natural teeth abutment, single tooth loss that would necessitate preparation of minimally restored or intact teeth for effective prosthesis. So if you having, for example, you have a missing central and you're having a lateral and you have a central, another central, to have a fixed restoration that mandates you to do preparation and reduction for the neighboring adjacent teeth. While an implant will save the natural tooth structure and will give you the chance to replace the missed tooth without sacrificing the natural tooth structure of the central and lateral. While it's contraindicated for the recent myocardial infarction patients, valvular prosthesis, treatment-resistant diabetes, generalized secondary osteoporosis, chronic or severe alcoholism, drug addiction, radiotherapy in progress, treatment of resistant osteomalacia, and finally having smoking. So you may find out that patient with systemic problems that there will be a chance of patients to have a compromised immunity would lead eventually to failure. So these are the list of contraindications of having an implant prosthesis. Now we need to understand and visualize the components and parts of an implant and the function of its parts. As we said in the beginning, in the definition of the process of a dental implant, we have the first part, which is anchored inside the bone and surgically inserted, which is called the fixture. It is the component embedded in the bone during the first stage surgery. It has internal threads. It has internally threaded portion that allows a second stage screw placement inside. The implant may incorporate an anti-rotational feature denoted by this like external and internal hexa within the design of fixture body, either internal or external, and that would prevent rotation of the abutment and loosening of the screw that may lead to failure of the abutment and movement. The cover screw. It is that part which seals the superior surface, as you see here, superior part of the implant during the healing period. Try to visualize after you do surgery and you place your fixture inside the bone, you would need to seal that part of the implant. Why? Because if you did not seal it, you would have accumulation of blood and interstitial fluids inside here that will further disintegrate or degenerate, and the body will start to recognize it as a firm body and start to develop inflammation, abscess, and edema. So therefore, that part should be sealed off to avoid this during the phase of osseointegration. It is usually low in profile, as you see it's flat, to facilitate suturing of the soft tissue over the implant. At the second stage, it is unscrewed, removed, and replaced by subsequent component. The next component is called healing abutment, or it has another name called gingival former. So hence from its name, it is used during the period of healing of the epithelium, and also from gingival, it gives a form of the gingiva at the interdental areas. These are dome-shaped, as you see here. It looks like a dome or bayani, placed of the second stage surgery before insertion of a prosthesis, as you see it here. So first you surgically insert the implant. Second step, you place the screw, cover screw, and then after the healing period, you use the healing abutment or the gingival former to give a form for the gingiva, to give a natural emergence profile. They range from 2 to 10 millimeter and project through the soft tissue in the oral cavity, made of titanium or titanium alloy. These healing abutments are responsible for smooth, healthy healing of the gingival tissue around the fixture orifice by preventing the growth of the tissues over the edge of an implant. These abutments should be left from 2 to 3 weeks to ensure epithelialization of the gingival tissues. Let us watch this small video, how it is as we said, the bone is drilled, screw or the fixture is inserted, and left for the process of healing and osseointegration before the stage of taking an impression and making the definitive restoration. So let's watch the video again from the beginning. First, we do a drill and notch, like an indentation to know where we're going to put our implant. First, we do probing indentation to check the depths of the soft tissue and the location of the bone. Do your incision, the flap, retract the tissues. Good. And then do your pilot drills and a guide. Check that your implant is placed parallel with the long axis of the teeth. Location should be directed toward the center of the tooth to be replaced. Then go with drilling stepwise from the smaller to the final diameter that you have planned to place your implant. Then insert your implant inside. Then this is the submerged part, and then place the gingival former and keep it until osseointegration is finished, and place your temporary restoration. Now, here comes a different part, the abutments. This is the part resembling, this is the abutment. This is the part resembling the prepared tooth. These are the intermediate component and implant supported fixed prosthodontics. So this is the intermediate component. You have this submerged inside the bone, and this is the crown, this is the superstructure, and this is the intermediate component. Abutment may take many forms. The walls are usually smooth, polished, straight-sided, made of titanium. The lengths range from 1 to 10 millimeters. They could be of one of two types, segmented and non-segmented. From the name, you can understand how it looks like. Segmented means comes in different parts that needs to be assembled. Non-segmented, it means it comes in one part. So we will discuss now the segmented abutments. Segmented abutments, they are composed of multiple pieces connected together. So as you see here, So this abutment is connected to the analog or fixture inside the bone through a screw. And the crown is connected with the abutment either with a screw or with a cement. In this case, an intermediate abutment is attached to the implant via a screw. A crown or a prosthesis is attached to the abutment either with a screw, as I said, or with cement. So in this condition, we have two screws, one attaching the abutment, this is the abutment, attaching the abutment to the fixture. And there is another screw, this one here, attaching the crown to the abutment. Screw retained element abutments. This abutment has got two screws. One is attaching the abutment to the implant body and the other one attaches the crown to the abutment. Cement retained, as I described before. These abutments can be shaped like conventional crown preparation. Their walls are usually smooth, polished, straight-sided, made of titanium or titanium alloy. The prosthesis should be cemented with temporary cement. This abutment allows correction of angulation problems for aesthetic or biomechanical reasons. This is the angled abutment. This is to improve aesthetics, to correct divergently placed implant, screw axis or the occlusal surfaces, facilitate oral hygiene, to avoid anatomic structure, example like the maxillary sinus here, or the mental framing here. Again, the segmented ceramic abutment, all ceramic component onto which all ceramic crowns can be cemented. Organic popularity for the anterior part of the mouth. These ceramic components are usually made of sintered alumina, zirconia, or combination of two. These are intermediate components, abutment, machined in a ceramic and prepared by precision milling, after which special porcelain is fired on the porcelain abutment to produce the final crown, like this condition. The non-segmented UCLA abutment. The UCLA abutment is not abutment for the University of California, Los Angeles, as we know UCLA. It is a unique, castable long abutment. This is abbreviation of unique, castable long abutment. One-piece prosthetic abutment consists of one screw. I'll go back with this picture here. It's one screw attaching the abutment to the fixture. It attaches to the abutment using a screw that pass through the occlusal surface into the implant. The non-segmented implant UCLA bypass the abutment portion by means of a sleeve wax directly to the implant. Using a non-segmented implant crowns may be necessary when soft tissue thickness is less than 2 mm. So this graph shows different forms of abutments. This is the standard screw retained. This is the cement retained. This is the angled abutment. This is tapered screw, and this is the non-segmented UCLA or abutment. At this phase, we finish inserting our fixture inside the bone with choosing the proper abutment. Now it is the phase of transferring the location of the implant and the arch for the laboratory to go and proceed with the preparation of the final restoration. For that particular purpose, we need to use the impression post or the transfer coping. Like as you see in this graph here, this is the transfer cope. Of course, it's not made of titanium, but it has the same dimension and it has the same screw channel with the same size because it will represent later on the same as the titanium abutment. The transfer coupe is a component used during impression procedure to transfer the position of the implant to the cast. They may be screwed into the implant or into the abutment and are therefore divided into fixture types and abutment type. So the impression post or transfer coping, fixture type, and implant type. So, for example, this is the impression post or transfer coupe. This is taking after taking the impression. This is the coupe, and that is the analog. They jack together. You place it in the imprint part. Then you inject all around the. After taking the impression, you inject the light silicone to represent the gingiva, and then you can. Now we go for the impression techniques. Implant impression technique, you would have indirect and direct, and the indirect method is called the closed tray transfer cap. Direct impression, uh, open tray or impression post. With the transfer impression coping in place, an impression is made intraorally. A heavier body impression material, polyvinyl siloxane and polyether are usually recommended, although any conventional impression material can be used. Syringe-loaded light body is injected around the implant abutment and transfer cap. When the impression is removed from the mouth, the impression coping remains in place on the implant abutment or on the fixture. The impression coping are joined to the implant analog before being transferred to the impression and the proper orientation, as you see here. So this is the impression caps over the abutments. After you take impression, the caps is transferred inside the imprints. Then this is the impression post, including this is the analog, which would be inside the stone, and this is the abutment. The final impression should be poured in dentin stone. The gingival tissue can be reproduced by injecting an elastomer to represent soft tissue around the implant analog. This facilitates removal of impression coping from the stone cast and the placement of subsequent abutment without breaking the stone and losing the reference point of soft tissues. Number 4, abutment analog are generally attached to an implant impression coping. Implant body body impression copings are normally attached to the implant body analog. So here's the process again. You place the impression coupe or transfer coupe. The transfer cap comes out with the impression. A simple the analog together with the impression pulse, then place it over here, inject the elastomeric light elastomers, pour the model in stone, all right, and then place your abutment and do your preparation and then the final restoration. Now let us watch this video with the process of impression, how it looked like to transfer the position of the implant into the cast. So we've seen the movie. Let us start again from the beginning. This is the healing abutment. is in position, and this is here what we do. We will unscrew the heating abutment here. Okay, then you would place the transfer cope for the impression post. This is the abutment, impression abutment or transfer cope. Then you will screw it into position, and this is the transfer cap denoted by the orange color. Then you will inject the light body impression material all around the implant abutment and transfer cap and the neighboring teeth. Now with the loaded tray with the heavy body, take an impression. Then you see here the transfer cap comes out with the impression post. Comes out with the impression tray. Unscrew the abutment or the impression post. Then replace it with the gingival former again until you end up with the lateral steps of the abutment and the definitive restoration. Now we go for the further steps of treatment modalities for the patients that comes to your practice asking for a dental implant. So implant therapy resolved many clinical restorative problems, among which single tooth implant restoration, distal extension, implant restoration, long edentulous span restoration, and completely edentulous patients to be restored with a fixed restoration. So here are the items that may be requested from patients, and these are the clinical situation, clinical problems that using a dental implant is actually gives another choices for the patient to be installed. We'll start with single implant restoration. Indication for this, it's simply if you are receiving a patient with, as you've seen in the graph here, patient with missing central. To have the tooth, missing tooth replaced, you need dramatically, with a fixed restoration, you need dramatically to do reduction for the neighboring teeth, which is it's a mass destruction for the natural tooth dentition, and even the dental lab technician, if even the best, you would never be able to replace the natural tooth structure, the natural beauty of the color of the teeth and the form. So it is used in case of intact dentition, I mean the neighboring teeth, dentition with the spaces that will be difficult to be treated by regular fixed partial denture, like if you're having a diastema. So if you have installed a fixed bridge, then you would have to make the teeth larger to compensate for the spaces between the teeth that makes the teeth looks uglier. Distally missing second molar tooth when a cantilever or removal partial denture are not indicated, and congenitally missing lateral, which is this is very often happens, and failure of endodontic treatment cases. So replacing a missing tooth using a dental implant, a single tooth implant, is a very good option for the patient, but still it has complications. And the main and the most common complication is associated with a single tooth is abutment screw loosening. Since the crown and the abutment is attached to the fixture with only screw, and this tooth or the replaced tooth would undergo function, so there is a possibility of this screw attaching the crown, the abutment into the fixture. There is a possibility that it will get loosened and possible fracture. So the implant must have an anti-rotational feature, therefore, to prevent rotation of the crown or the abutment. Implant should be made of titanium or titanium alloy for strength. Threaded implant, greater surface area. Diameter should range from 3.5 to 6 millimeter, posterior region. Length should range from 9 millimeter to 15 millimeter. The anti-rotational feature, these are components uh, that is will prevent the rotation of the abutment, direct mechanical interlock or anti-rotational feature, and this is quite seen here. This is the internal hex and this is the external hex, with the screw will go all through the abutment going into inside, so this will prevent rotation and will make it um, more stable into position. Here is the form. Now we come for the next option of using an implant. in clinical situation like the distal extension implant restoration. It is partially edentulous cases with no terminal abutment for regular fixed restorative options. Implant-supported restoration offer a great advantage. That means in cases, for example, if you have the last tooth in arch is tooth number 6 and you don't have the tooth number 7, so there is an option of having it either cantilever or having it as a partial. So using an implant in the distal part is a very good option for that. There are two distal extension restorative procedures or options: either implant-supported restoration or tooth implant-supported restoration. And this is usually we use it in cases if you're going to have, for example, a bridge, for example, like 3-unit bridge. So implant-supported restoration, placing two or more implant posterior to the most distal natural tooth and fabrication of a completely implant-supported restoration. Preferably one implant is used to replace one tooth. In favorable cases, the use of two implants to replace 3 or even 4 missing teeth may be done in case of good bone condition. Tooth implant restoration. This option includes placing one implant distal to the more posterior natural tooth, like here in this condition, and fabrication of a fixed partial denture connecting the implant with a natural tooth. Splinting implant with a natural tooth is not recommended due to different supporting elements. Failure may occur in either one of the restoration, either breakdown of osseointegration around the implant, cement failure on the natural abutment, screw or abutment loosening, failure of the implant prosthetic component. Sometimes patients has long edentulous span with improper distribution of abutment, or the abutments are not good enough to support long fixed prosthesis. So this choice of line of treatment depends on the length of the span, quality of the remaining bone, predental condition of the remaining teeth, economic status of the patient. It could be by restored by implant supported restoration or tooth implant supported restoration. We may use a hyperprothesis, which is combination between the concept of removable and fix it, or use metal ceramic restoration in case there is no bone resorption. So we have the two modalities of treatment: fixed metaceramic restoration in case of no or moderate, hyperprothesis in case of great bone loss or soft tissue loss. Choice number one, the fixed metaceramic restoration indicated in case of minimal bone and soft tissue loss. Use of screw retain type of restoration allows the dentist access for cleaning and repairing, like this case, and here's the final restoration. A hyperprothesis is a prosthesis that combines the principles of conventional fixed and removable prosthodontic, used in long span edentulous spans requiring reconstruction of soft and hard tissues. In these cases, it is better to use resin teeth persist to metal substructure rather than conventional metal ceramic restoration. How to retain a restoration to an abutment? Either we use screw retain restoration or we use cement retained restoration. These are the main concept of retaining the prosthesis into your correspondent implant abutment. Advantages of a screw-retained restoration: easily retrievability of the prosthesis, connection mainly by machined abutment, no need for luting cement. But it has this disadvantage of bad aesthetics, sometimes screw emerge on the occlusal surface that may interfere occlusion, difficult occlusal adjustment, screw is liable to loosening or fracture, more liable to porcelain fracture. Cement retained restoration, cement implant, cemented implant crowns can be luted to a screw retained abutment. Zinc, phosphate, glass enamel, and resin cement may be used. However, permanent cementation limits the retrievability of the restoration. Therefore, provisional cements have been suggested as they allow restoration retrievability to clean and to adjust and to repair the prosthesis. Advantages of cement retained restoration: good aesthetics, allow minor angle correction, more economical, cement ensures passive adaptation of the metal framework, significant resistance to screw loosening, high resistance to screw fracture, and facilitate occlusal adjustments. Disadvantages: retrievability is difficult when permanent cement is used, risk of irritation due to subgingival cement excess. With completely edentulous patients, there are two fixed restorative options: fixed metal ceramic restoration. Some number of implants need us for hybrid restoration, indicated in case of minimal and soft tissue loss. Use of screw retain type of restoration allow the dentist access for cleaning and repair. As you see here on the graph, a hyperprothesis is cast alloy framework with a processed denture resin base and acrylic resin teeth. A minimum of 5 implants is recommended in the middle and the mandible and 6 implants in maxilla. It is indicated for patients with moderate bone and soft tissue loss as it restores bone and soft tissue contour. No, please, in case of extensive bone and soft tissue loss, removal restoration is unavoidable. The graph shows restoration with effective prosthesis using implant, both arches, upper and lower. As we said, it's the minimum 4 for the lower for the mandible and 6 for the maxilla, and that would depend on the quality of bone. Now we move to another story here, how I can judge that my implant is, or the implant prosthetic is successful. First, no peri-implantitis, circular black accumulation with associated loss of pseudoepithelial attachment, no peri-implant radiographic radiolucency, tissue integration, bone and soft tissue, osseointegration, absence of mobility, stable clinical attachment level, absence of bleeding upon probing or excessive probing depths, absence of discomfort. This is how we can judge that your implant is successful. Now let's go for the failure of an implant prosthetic. The main or the primary complication with dental implant therapy is bone loss around the implant. Multiple factors are associated with the implant loss, like inappropriate size and shape of the implant, inadequate number of implants or implant positioning, poor quality of the available bone, initial instability of the implant, compromised healing phase, inadequate fit of the prosthesis, improper design of the prosthesis, excessive occlusal forces, The efficient fit of the abutment component, deficient fit of the abutment component, inadequate oral hygiene, and systemic influence like tobacco use. The prosthesis itself could fail, and this could be additional implant prosthetic complication include the fracture of the implant component or the prosthesis. Fracture of the implant component is usually attributed to fatigue from biomechanical overload. Here are some questions you may find in the PDF format. You can go through and try yourself. I wish you all the best, and thank you very much.